Oh, hi there. Well, you just saw us practicing for the airway management. Kyle, you can actually stop now. We're just practicing.
Yeah.
But we're practicing airway management techniques during a crisis. So one of the things that we thought we'd show you first is the correct way to manage an airway when you have time and it's not a crisis. This is not the way to do it. And then after that, we can kind of compare and contrast how airway management differs when you're in a crisis and you're doing chest compressions. And in this module, we're not only going to learn about airway management, but we're also going to learn about access, whether that's intravenous access or even intraosseous access to the patient, which is also very important during crisis because, of course, that's the way that you give most of your drugs. So let's get started. Let's take a look at how you can handle airway management in a non-crisis situation. So let's talk a little bit about airway management in a non-arrest setting. Now this is very different. The first thing you're going to notice is that the bed is up high. It's almost here at my belly button level. This is because the bed height at this level really helps facilitate endotracheal intubation for the operator. Obviously, if you're in a code situation, compression takes the priority. And the bed has to be much lower in order to facilitate the compressor performing chest compressions. As you can see Kyle demonstrating here, that's really not possible when the bed is this high. The other thing is you'll notice that the patient positioned much more towards the head of the bed in this non-arrest situation, which you might find, an elective intubation in the ICU, for instance, is one of these situations where the patient is not in arrest, is hemodynamically stable, but requires intubation for some reason. Also, you'll notice that the patient is in a sniffing position, the flexion and extension of the neck to facilitate endotracheal intubation. Now, I'm not actually going to take you through all the steps of endotracheal intubation because, what we know is that if you don't regularly perform endotracheal intubation, you shouldn't be doing it in a code situation. And there are other techniques that you can use, such as laryngeal mask airways, or even mask ventilation. Let's actually talk about mask ventilation. This is a very useful technique that can often give you time and bridge the period between apnea and when you can secure the airway. So what we want to do here is to apply the mask to the patient's face, starting at the nose and continue down and tilt down. And then with your your fingers here, lift up on the jaw and create a seal. And sometimes you might have to rock back and forth to get a good seal. And then you can go ahead and give a breath. And what you want to do is watch the patient's chest rise and fall with each breath so that you are confirming that you can ventilate the patient. If you have difficulty, there are things that you can do to help facilitate mask ventilation of a patient. One of the most common things is insertion of an oral airway. You can take an oral airway here, and you can insert it into the patient's mouth upside down, and then turn it around properly, and then go ahead and try mask ventilation again, and see if that can help you. Now there are other airways that you can insert as well. You can also insert nasal airways. If you insert an oral airway and you're not still getting good ventilation, you can go ahead and lubricate a nasal airway and insert that into the patient. Okay, so now when you're ready, you can perform endotracheal intubation. As I mentioned, the height of the bed facilitates this. We're not going to go into all the steps of it today. That's really beyond the scope of this tutorial. The key, though, is to really open the mouth widely, start from the side, and then sweep the tongue out of the way. Tell people what you're seeing. I have a grade 1 view. And when you have the grade 1 view, don't look up to see where the tube is. Someone will hand it to you. And keep that visualization on the glottic opening. And then once the endotracheal tube is in place and the cuff is past the cords, then you can now remove the stylet. You can inflate the cuff, and you can have an assistant ventilate the lungs. Now, how do you confirm endotracheal intubation? What you can do is watch for chest rise. You can also auscultate the lungs to confirm bilateral breath sounds. And most importantly, you should check for end-tidal carbon dioxide using continuous CO2 monitoring. And that is airway management in a non-arrest situation. So now we have the bed set up for optimizing conditions for the compressor during a cardiac arrest situation. As you can see, the bed position is markedly different than the previous situation where we tried to optimize everything for airway management. And as you can see, the bed's much lower. This is so that you can aid the compressor if you want to demonstrate, Kyle, how the bed position is now much more optimal for the compressor, providing compressions for resuscitation. However, that comes at the expense of obviously the person managing the airway, because they're now much lower to the floor. The patient's not necessarily in the sniffing position, not necessarily towards the head of the bed. Let's talk a little bit, Kyle, about optimizing conditions for airway management. Is it reasonable to pause CPR so that we can get the patient in the optimal position for airway management so we can intubate the patient?
It is not. This is a big difference from before. You should never interrupt compressions to secure an airway. Let me emphasize this strongly. Compressions are the priority. Airway management comes secondary. Either you achieve adequate ventilation with bag mask ventilation, or you attempt to intubate in the condition that you find the patient, or you place a laryngeal mask airway. If you get the patient back and you get a return of circulation, then you can secure the patient airway. The studies show that when people fixate on airway management, they neglect compressions. They have compressions stopped, they reposition the patient, they do things that limit and inhibit effective chest compressions.
No, but I always hear people say ABCs. It's airway, breathing, and then circulation. Isn't that the same? Don't those things hold true for cardiopulmonary resuscitation?
So it's CAB now, compressions, airway, breathing.
Okay. So it has changed.
It has changed.
Okay.
And you're often able to get at least marginal ventilation, which is all you really need is to get a little oxygen in. You're not going to try and really ventilate these patients aggressively. We already went over that. Aggressive ventilation is actually detrimental. Large tidal volumes, long inspiratory holds, high respiratory rates, all cause negative performance with your compression. So less is more. Do what you can. We do have some techniques that we can quickly show you on how you can improve things. You can try and bundle a direct laryngoscopy with a pulse check, but like I said, we want anything that's not a compressing event to be less than 10 seconds. It's actually pretty hard to intubate someone in less than 10 seconds. And then they got to start. They can't wait for you. They got to start compressions again as soon as they can. So get away from this idea that you're going to intubate everyone in an arrest. Just figure out how to effectively ventilate the patient. So we went over bag mask ventilation before. We talked about laryngeal mask airway. So I think that's something to discuss.
So let's recap a little bit. If you're coming to a situation where the patient is having a cardiac arrest and compressions are occurring, you should try, in terms of managing the airway, to do bag valve mask ventilation. If you can establish ventilation through that method, then you don't necessarily need to move immediately to an tracheal intubation. Now, however, if you are somebody who does endotracheal intubation on a routine basis, if you're an anesthesiologist or another physician who's comfortable with performing endotracheal intubation, it may be reasonable to attempt endotracheal intubation between compressions, but certainly don't hold chest compressions. Now, if even that expert cannot achieve endotracheal intubation, it may be reasonable after a period of mask ventilation to attempt laryngeal mask airway placement. But again, to recap, certainly don't pause chest compressions, don't pause CPR in order to secure the airway.
And let me just make sure that's clear for our viewers. A laryngeal mask airway is something that you could probably do yourself. It is not that hard to place. It's actually, the data is actually stronger for a more favorable outcome if you place it early. So I don't want to give the sense that this is the last ditch effort. This is something you might want to move to very quickly because it is considered an advanced airway. You can then do continuous compressions and ventilate the normal reduced rates of 6 to 10 breaths with an LMA, just like in a tracheal tube. If you're doing bag mask ventilation, you still need to coordinate the 30 to 2. So
it's 30 chest compressions to 2 positive
Ventilations,
pressure
yeah.
mask ventilations. But if you do an advanced airway technique, or you are able to secure the airway within a tracheal tube or a laryngeal mask airway, then you can give breaths during chest compressions.
Right. Continuous compressions.
And the rate?
And the rate, definitely less than 10. I shoot for around 6. It's actually very hard to do. Do you know what the actually average ventilation rate is during an arrest?
Higher than that.
I assure you. It's about 30. Do you know why it's 30? You can't squeeze an ambu bag any faster. Trust me, this is something that's going to happen. People are going to overventilate. You have to watch for it. You have to correct your team. And you got to make sure they don't give big tidal breaths because you may get them slowed down, but then they're going to just give these big tidal breaths. It's little puffs just to get some oxygen into the patient.
Great. Well, I hope we've given you some tips on airway management. The next thing we're going to go over is access, vascular access.